So thank you again to Barbara, Amy, and all of you for this opportunity to share a little bit about my experience over the last 5 months working with critically ill patients with coronavirus, and just some general observation about the pandemic and where we're heading from here. So these are my thoughts, my interpretations of my experiences, and really the best appraisal of the literature that I can provide, and integrate that with what we have all experienced and lived through over the last few months on the front lines. Here's what I hope to accomplish today. We're going to go over the background and talk really about the definitions and what coronavirus is. We'll talk about how prevalent it is and how widespread the problem has really become. We're going to look at the symptoms and how patients present and what effect the comorbidities have on the progression of disease and risk of developing severe disease. We're going to talk about available treatments and say a few words about the antibody response, as well as where we are with developing an effective vaccine. We will also review preventative measures that are vitally important as we move forward. And we'll talk about the impact on other conditions, including other physical and mental health diseases. And then we'll look a little bit to the future and talk about some future directions. So by way of background, it's a little bit of an alphabet soup every time a new disease emerges. So this is a new virus that has not been previously described. You will read about it with various abbreviations. The important distinction to remember is SARS-CoV-2 is the virus, and you can see the acronym there, Severe Acute Respiratory Syndrome Coronavirus 2, to differentiate it from 1, which we saw a few years ago as a much smaller outbreak. COVID-19, which stands for Coronavirus Disease 2019, because that is when it first started being reported out of China, is really the disease that the virus causes. So SARS-CoV-2 is the virus, and that's what you will read on some of the lab reports if you're ever getting a coronavirus swab, and COVID is the disease. As I said, we first started learning about this as cases of unexplained severe pneumonia started coming out of China in late 2019. In November and December, there were clusters of patients getting admitted who were getting really sick with pneumonias that were otherwise could not be explained by any of the known diseases. We think the best idea right now is that it came somewhere from an animal host and then jumped to the human, has not been seen in the human population before. And it is similar to the viruses of SARS and MERS that have previously caused epidemic outbreaks, although not on a pandemic scale. If you can see on the bottom right of your screen, that is an image from the CDC. So coronavirus is a family of viruses, and these little red spikes, apparently to someone, were reminiscent of a corona, which is a word for crown. And so that's the name of the family. The family contains these sinister viruses, as well as at least 2 other viruses that cause common colds and are not nearly as deadly, but they're all part of the same viral family. What we know about this particular virus that causes COVID-19 is that it is incredibly contagious. So you will read about some of these statistics. Currently, the R0 is the number of people that anyone with COVID can infect. And the CDC currently estimates that number at 2.5. So any one person with coronavirus can pass it on to over 2 other people. That results in a doubling time that's currently estimated to be anywhere between just over 2 and 7 days. So in other words, in under a week, we can go from having 10 patients with coronavirus to having 20, and another week to having 40, and so forth. The goal really, in order to really get a handle on this pandemic and for it to start receding consistently around the world, is to try to get that R0 number to less than 1. So the virus just doesn't continue to spread by leaps and bounds, which it's currently doing. Another important point about this particular virus that really wasn't seen with SARS or MERS, and isn't seen as much even with seasonal influenza, is that there is a great deal of asymptomatic and pre-symptomatic transmission. So there's a fraction of people who will get infected with SARS-CoV-2 and never develop any symptoms, and those are the asymptomatic patients. And then there are those who are going to get infected and are going to be able to transmit the virus to other people. And we think right now about 2 days and up to 5 days prior to showing any symptoms. So somebody in the grocery store walking around looking and feeling perfectly healthy and not otherwise indicative of any problems can be infectious and can spread the disease. And currently the CDC thinks that up to half of the cases of coronavirus that we actually are seeing as disease are a result of this asymptomatic or pre-symptomatic spread. So clearly a huge issue. This is a map from the World Health Organization from about a week ago. The colors really haven't changed. It's an absolute scale. You can see the US right here with the darker colors mean more cases. So interestingly, there are lots of parts of the world, as you can see, that have more cases now than China, where the outbreak originally began. And this is a good reminder that in our day and age, we really live in a very global community. There are very few things that are going to become really localized problems. This is a global pandemic. Again, a week ago, when I pulled these numbers less than a week ago for this presentation, this is what the case and the death rates look like around the world. There are now over 22 million cases that are just reported to the World Health Organization, we're approaching 800,000 deaths globally, so in 795. So in the last 6 days, there's been over 30,000 additional deaths worldwide. In the US, we are up to 5.5 million now, and 173,000 deaths. So in the 6 days since I put together this slide, there's been 6,000 more Americans who have died. And for the last month, there has been the majority of the days, I think 24 of the 30 days in the last month, there's been over 1,000 people per day dying of coronavirus. And as you can also see at the top of the slide, the US really only represents about 4.25% of the world population. However, we have had consistently with all these numbers about 1/4 of all cases and just under that of relative percentage of all the deaths. The CDC usually takes a few years to put together their mortality and top causes of death data. This is the most recent actually that's available in 2020 is 2017. I will tell you that usually kind of the bigger suspects, the usual players of heart disease and cancer are 1 and 2, and that doesn't really change very much. So you can see if we put coronavirus on there, again, a week ago, this was just under number 3, but as you've probably seen in the news, now with 173,000 cases, this has actually gone beyond the number of accidental deaths and is now the 3rd leading cause of death. Again, keep in mind, these are 2017 statistics, but that's the most recent ones available. And as you can see, number 8, there's influenza and pneumonia. The flu kills about 20 to 30,000 patients every year in the US. And when people say, well, it's just like the flu, it's clearly not just like the flu. And by the way, severe flu terrifies us as physicians as well. So none of these things are to be taken lightly. Now, the distribution of patients who are getting sick, getting hospitalized, and unfortunately dying from this disease is not uniform. This is a composite chart based on CDC data that the Brookings Institution has put together, showing that for every age group, you can see the height of the orange bar, which are patients who identify themselves as Black, and then the height of the gray bar, which is patients of Hispanic and Latino descent. Those bars are all higher than the corresponding blue bars, which is white patients. And many states have now reported that their rates of hospitalization and death for patients of color far exceed the proportion of the population that these patients of color have in their respective states. So it's described initially, and it's even in the name, we talked about how it's an acute respiratory virus, and certainly respiratory failure is the most feared and the most severe complication, but this is a disease that affects the entire body. People can present with symptoms ranging from just not feeling well and feeling tired and losing appetite and being achy all over and having fevers and chills, to cough and shortness of breath, leading all the way down to needing oxygen to help them breathe. They can also present with nausea and vomiting and gastrointestinal symptoms, sometimes in the absence of respiratory symptoms. They can have cardiac side effects. They can present with strokes, especially young patients. You have probably heard about the loss and sense of smell and taste as one of the sort of telltale signs. And then the increased clotting, which sometimes can lead to those strokes in patients who are 30 and 40 years old and are otherwise perfectly healthy and have no other risk factors. There's a wide variety of symptoms. Now, this list has been revised many times by the CDC since they really started publishing a lot of guidelines on this in March. Now, overall, the good news is the majority of patients are actually going to have non-severe disease and they're going to recover. However, there's now growing recognition that even in people who never needed to go to the hospital for COVID, they may have symptoms that linger for several weeks to months, and we just don't have more longitudinal data, so we don't actually know if those patients are ever going to have complete resolution of all of their symptoms. Now, the list below is what the CDC currently calls as definitive risk factors, and there's a list of about 20 other risk factors that are probable risk factors for someone if they have these underlying conditions that are going to develop potentially more severe disease. So currently the definitive list includes heart disease, pulmonary disease, chronic kidney disease, obesity, cancer, diabetes, and being immunosuppressed from an organ transplant, as well as sickle cell disease. Now, smoking now makes the list of these probable, so most likely the data just aren't as strong. And I will tell you, and as we will hear more from Dr. Nikolakakis in terms of effects of the vaping epidemic. Now, patients who use either regular smoking or e-cigarettes, there is a proportion of patients who do not recover fully their lungs, and e-cigarettes create an intense inflammatory response in the lungs. So somebody with any pre-existing lung injury then getting COVID on top of that is certainly not going to be faring as well as somebody with lungs that are perfectly healthy. And there's laboratory data to examine whether or not e-cigarettes themselves, the inflammatory response that they produce, actually make someone more likely to catch coronavirus, like we have seen with some other diseases like other types of pneumonia. Now, on average, the kids are going to develop milder symptoms than adults, but they're certainly not immune for problems. There's a minority of kids who are going to get increasingly very ill and actually require hospital or ICU admission. About 9% currently of all the cases in the US are in patients under 18. And then weeks later, after their acute coronavirus infection, they can develop, which you may have also read about, this multi-system inflammatory syndrome, this pretty severe syndrome that frequently results in them needing to be in the hospital and the ICU. And there have been about 570 cases of this syndrome reported to the CDC just this year alone. Now, kids are also obviously very important in the public health picture in terms of being potential spreaders of the disease. So even if they're not going to get very sick, you know, potentially they're going to go back home and infect their parents or grandparents who may have some of these underlying conditions. And certainly these conversations are very pertinent when people are talking about reopening schools. And one really needs to look at the underlying prevalence and how well the school system in each particular district is able to comply with some of these infection control measures that we're about to cover in subsequent slides. Now, the disease, if you ask any one of my colleagues or really anyone around the country who has been in the thick of it, we will all tell you the disease is incredibly humbling. It offers some unique challenges. It has a very variable clinical course. We don't have a way of predicting which patients are going to do just fine and which patients are going to develop severe disease. And in some of the patients, we believe that the problem is that their immune system, their defenses that their body is mounting, are just not strong enough. And in other patients, they're probably too strong, and the defenses themselves are harming the body and the ability to fight this infection. We saw a similar discussion during the 2009 H1N1 influenza pandemic as well. Now, a lot of patients also have, as I mentioned, this variable course, and sometimes people can seem to either stabilize or get better. And then around day 9, 10, or 11 of their infection, of when they first develop symptoms, they have this cliff that some of them just fall off of. And it's incredibly humbling and scary to watch, because in a matter of hours, somebody can go from being just fine to needing to be in a breathing machine because their oxygen levels drop so precipitously. Now, patients then can have additional events, so cardiac events, and frequently those are seen just anecdotally after their respiratory failure sometimes gets better. So just when we think that somebody is out of the woods, sometimes there's some of these other organs that begin failing. And it is, again, it is difficult to predict which patient is going to go through that. Makes it, as you can imagine, very difficult to care for them and anticipate these things, and also to guide their families as to what may happen next. Now, patients who do go on to survive their critical illness have an incredibly prolonged course when you talk about healthcare utilization. It's because these patients on breathing machines and on breathing machines in our ICUs for several weeks, which is way longer than we normally see with any kind of other type of respiratory failure. And then they're very ill, and then they have a prolonged period of recovery that's yet really to be better characterized, because we just don't have a lot of these survivors who are out, 6 months or more for us to really make conclusions about longitudinal courses. Now, we'll talk about treatment when the lockdowns and the closure of schools and other things started back in March. We really were offering these patients best supportive care, which certainly is a lot, but we didn't have any targeted therapies specifically for coronavirus. Now, we're faring better now. I'm going to talk about these two treatments quickly. One is Remdesivir. It is not a new drug. It's actually been around for more than a decade. The company that developed it, Gilead, tried it for hepatitis C, didn't really work very well. Then they tried to repurpose it for Ebola. There are some good signals in early studies, but it still wasn't very effective clinically. And then there are some animal models that shows that it has activity against some of these other coronaviruses in the same family as the SARS-CoV-2. So there was an earlier trial in China, a randomized trial that came out that everyone was really anticipating in March, and unfortunately that trial was negative. So the patients who got Remdesivir didn't fare any better than the patients who didn't. There was another randomized trial that was more promising, over 1,000 patients enrolled, and those are people who came in with COVID and pneumonia. So not just anybody walking around, these are patients in the hospital who already had pneumonia. And Remdesivir helped patients get better faster. Now, patients who got Remdesivir also tended to have a trend towards better mortality, but it wasn't statistically significant, which means that question really isn't definitively answered. It is not a magic bullet. It cannot be used in patients with renal failure, which is a large percentage of critically ill patients with coronavirus. And it also has major side effects, including liver toxicity, which also precludes wider use. Now, this is a snapshot of the actual trial published in the New England Journal, which is the preeminent publication and a leading journal. And in my career, it is completely unheard of that in a span of several weeks, the journal will publish one, and then I'll show you the subsequent paper as a preliminary report. This just underscores the hunger that we all have in the medical community for anything that works against this virus. So they're willing to push out data and reports based on any promise that's out there. This also means that subsequently larger trials may show us something different that we don't yet understand, but this is the best evidence we have right now. So without going into too much detail, you can see that Remdesivir, the blue line's at the top, and the graph on your left is all patients, and the graph on your right is patients who are receiving oxygen. And the days are on the x-axis, and you can see that compared to placebo, compared to people who didn't get the drug, Remdesivir helped those patients recover faster. Now, it wasn't all well and good, because on patients who were the sickest of the sick, who were on breathing machines or on cardiopulmonary bypass machines, so requiring kind of the most advanced technology we have to support those patients, they actually didn't have any benefit from Remdesivir. So this definitely needs to be studied more, but this is one of the best treatments we currently have. The next one we're going to mention is Dexamethasone, and then the word for it is Decadron. Now, this is a drug, talk about repurposing all drugs. This is a drug we've had since the 1960s, which is a very potent anti-inflammatory, used to treat many, many different disorders. And there's a trial that just recently came out showing that Decadron actually improved mortality. So patients who got the Decadron actually were living more than the patients who did not. Again, same exact idea, same journal, and same preliminary report, right? So more can be said and done when all the data are finally analyzed. But this is the graph. So mortality, which is on the y-axis, was lower in patients who received Decadron. I also want to call your attention to the fact that this mortality figure, we want it to be right here. We want it to be 0. So again, this is not a magic bullet. This was significant in this trial, and we're excited to have these results, but we're far from having a cure. People who were on breathing machines in graph B, got more benefit. People who were receiving oxygen by something other than a breathing machine, such as a nasal cannula, also got benefit. However, people who did not receive oxygen, you can see the graphs are unfortunately flipped. So this wasn't statistically significant, but this was a concerning signal. So far, this is another way of displaying the same data. This line is the line of equivalence. So anything to the left of that line is Decadron was better for these patients. Anything to the right, it was clearly worse. So it's this little bar here crosses the line. So it's not clearly worse, but this mean here being on this side of the line is definitely concerning. So we do have promising treatments and they're widely used. However, they're certainly not without side effects and they're not a magic bullet. So what about the immune response? Can someone who have already had coronavirus develop the disease again? How long does the immunity last? What about herd immunity? The best way to answer all of these questions is we really don't know. There is a lot that's being studied and postulated. The best we can say right now is people who have had coronavirus have a range of antibody responses. Some will have a lot of protection against a future infection and some will have not as much. And we think it's at least partially protective. That means that even if they were to go on and get coronavirus again, they probably are not going to get as severely ill. But we really don't know how long the immunity lasts. And herd immunity refers to enough of the population having been exposed to the virus, either through getting sick or a mass vaccination campaign, that the virus just has no more hosts to spread to. So the best estimates are really anywhere from 50 to 70% of the population. So we're far, far off from reaching that. If we were to just let everyone get exposed and get sick, that would result in hundreds of thousands of deaths because of how deadly the disease is. So that's really not an option. Our best bet there is waiting for a vaccine. There's some suggestion that maybe T cells, so the B cells make antibodies. T cells are a different type of cells in the immune system that also help us fight infections. So it's possible that people have some degree of protection from having been exposed to some of these less deadly common cold coronavirus infections, but this isn't as protective. And again, it's not that they're not going to get coronavirus, they may just get milder disease if they happen to get sick. So a lot more to be studied on this. Now, currently there are 3 vaccines that we're really tracking in the US in clinical trials. Now, the development of a vaccine usually takes many, many years. And there's been unfortunate examples in the past where they've tried to rush vaccines to market and then found that they were not only not helpful, potentially they were harmful and had side effects that were not previously seen in some of these smaller trials. But there 3 vaccine candidates currently in the final stages of development, so phase 3 or combined phase 2-3 trials. By the most optimistic estimates, we should have the results of some of those trials coming back, probably again in preliminary form, coming back by the end of this current calendar year, which means by the time that I or any one of us can go out to CVS and get the vaccine, we're really talking about 2021. Now, in the absence of a slam dunk cure and while we're still waiting for the vaccine, what are we left with, right? You're going to say, Dr. Kehl, this is all really depressing. You've shown us this is a huge problem and people get really sick and then the treatments are promising, but not really curative and the vaccine isn't here yet. What can we really do? So the great news is that there are these really effective measures that we can all do and should be doing and should be taking in order to prevent the spread and really get a hold on this pandemic. Physical distancing, social distancing is really the term that's most often used, but the important thing is that you're not socially distant from those people. The important thing, you're physically far apart. So if one of you or both happen to be sick, that you're not close enough to catch the virus. Universal wearing of masks, correct and consistent use, and we will go through that in subsequent slides. Washing your hands, using hand sanitizer, and disinfecting your surfaces. And this is now uniformly recommended by the CDC, the WHO, and every medical society out there. Now, there won't and there shouldn't be a randomized trial where half the people are going to put on a mask and the other half are not, and somebody with coronavirus is going to cough on them and we're going to see how well the masks work. So we're not going to have that trial because that's really not ethical to do, and we know people are going to get exposed to the virus. So we have these corollary studies, but I'd like to call your attention to 2 that talk about the effectiveness and the reason why we're really pushing for universal mask use. One is the study looking at, literally measuring the viral particles in the air around someone who had either influenza or whether these other seasonal coronaviruses, and they either breathed out or coughed, and then the researchers measured how much virus is there. And if those people had a mask on, the amount of virus around them that they were spreading was significantly decreased. There was a case series, a very interesting case series that came out of Beijing where they studied families and household mask use. And the important point of that study was that if people are consistently using masks, then the risk of transmission goes down by about 80%. And it's most effective when they had masks on all the time. If family members of someone who got sick only put on a mask after the sick person started coughing or sneezing, that the mask didn't actually help. So it's really important to have them on all the time when you're in contact with people who are not your immediate family. Now, this is what the CDC wants you to see. I think they're emphasizing physical distancing as well. These people are kind of far apart, and that's the best we're going to get. Your mask may protect them, and their mask may protect you. So you're really wearing a mask for both protection of you, but also in case you happen to be in that pre-symptomatic or asymptomatic group, to not spread the disease beyond just your person. The American Thoracic Society reminds us of the appropriate technique for wearing a mask. So it needs to go tightly around your nose. It needs to cover your nose really well, not cover your chin completely. And lots of studies in kids show that kids actually have a higher amount of virus in their nose than their mouth. So make sure that everything is covered, their nose and their mouth, and the mask is fitting appropriately and it's not sliding down to their chin or is not, worn around one ear. Now, we've talked about the virus itself. What has it done to our other patients? In the month of April, in my ICU, we didn't have a single patient who wasn't there with COVID. And we were all wondering what's happening to all these other patients that we normally see with heart attacks and strokes. And so what was happening to them is a lot of them were staying at home and scared to seek medical care because they were worried they were going to catch coronavirus in the hospital. So you see that spike right at the end. I just showed you the graphs for heart disease and diabetes. This spike and this spike right here, these are excess deaths in the months of March and April, just for these 6 states that are represented there, that are not due to COVID. So again, this is not COVID mortality. These are people who lost their lives, who did not have coronavirus, but during the months of the pandemic and the lockdown, they probably did not seek medical care fast enough, and that's the excess effect. Now, COVID and the pandemic have certainly also had a tremendous impact on the mental health, at least in this country, and I'm sure worldwide. This is data from a survey of about 5,000 US adults. And when they talked to them in June, they said, in the last month, have you had any of those symptoms? And this is staggering. So 40% of people in that survey reported that they were struggling with either a mental health or a substance use issue, which is really all one part or parcel of the same problem. 11% seriously considered suicide. Now, just as a background comparison from the same time last year, the general prevalence of anxiety and depressive disorders in the population is about on the order of 10 to 11%. So this is a huge increase for a healthcare system that was already taxed by the pandemic. Now, this stems from difficulties in accessing mental health and addiction treatment services, as I'm sure Tony will tell us in the subsequent talk. There are stressors that everyone is dealing through, but they're particularly felt by people already with underlying mental health conditions. And remember, these are patients who have mental health diagnoses, and these are patients who are developing these disorders as a result of some of these stressors like social isolation, job and housing loss or insecurity, and anxiety and fear of contagion and fear of what's going to happen to their families if they get sick and they have no one to take care of their kids or their loved ones. Now, the majority of the states are reporting an increase in opioid-related overdoses and unfortunately deaths just during the pandemic, again, because of all the factors we just mentioned. So this is a huge problem that's affecting everyone, whether or not you're actually the one sick with COVID. So we covered a lot here. This was kind of a big 30,000 foot view. But I want to leave you with the following thoughts. We know a lot more right now than we did 6 months ago. We have proven infection control strategies. We have promising treatment options, and we can certainly do a lot while we're waiting for the vaccine to be available, which hopefully is on the horizon in the order of several months. Now, there are lots of questions that still remain. We don't know what lingering effects this is going to have on survivors. There's this enormous physical and mental health toll of the disease and the pandemic that we just talked about. And we don't really know how to well separate the waves, the first wave and the second wave, because the cases have been peaking in different states at different times. All the healthcare community is uniformly concerned for the fall. People are talking about a potential twindemic, so an ongoing coronavirus pandemic, and then the influenza season upon us. So please, please all get your flu shots when they become available through your doctor or through the pharmacies, because you definitely don't want to add insult to injury, and you want to do your part in preventing at least the diseases that we now can prevent. So the good news is everyone can and should do their part in helping to control the pandemic by following these infection control measures that we reviewed. I'm telling you this as a physician. I'm telling you this as a mother. I'm telling you this as someone who's been on the front line seeing these patients, and I'm asking you this also on behalf of these family members who, just like you and I are talking now over Zoom, these family members had to say their final goodbyes to their loved ones with me or one of my colleagues holding an iPad in my shaking hands at the bedside of their loved one who's taking their last breath. And they had to do this over Zoom because they were not allowed to come physically into the hospital for the fear of spreading the virus. And most hospitals had a no visitation policy. So think about, when was the last time when it was so easy for every one of you to save a life, potentially your life or life of your loved one, or life of someone you may even know who you may transmit the virus in being an asymptomatic carrier. So with that, I'd like to thank you all for your attention, for giving me a few minutes of your time, and I'd like to open it up for questions and remind you, that if Mickey here can figure out a way to appropriately wear a mask, then we can all certainly do our part, and we will get through this together. Thank you all so very much.